네, 오늘 EKG 컨퍼런스 먼저 시작하도록 하겠습니다. 첫 번째 케이스 심전도입니다. 먼저 얘기를 하셔야지.
처음에는 네로 큐아를 보였는데 PVC가 있으면서 뒤에는 V체도 뒤에는 미드로 이 웨이브는 사이너스일 때 X로 저처럼 하고 위에 V택이 있는 P 웨이브가 있습니다. 여기에 있는 것
그래서 BP,
네.
선생님 BT 쪽으로 페이버한다고 있고 항상 결정적으로 얘기하지 마세요. BT 그렇게 보내주셔야 조심호 선생님이
말씀드린 거 외에 일단 그 마이스타레스 파스타리아로 있는 거는 그 네, RBDG 패턴을 들고 있는데 왼쪽 뒤보다 왼쪽 뒤보다 오른쪽 라이트리어가 조금 더 폴라하고 포지티브 컨퍼런스를 해소달리게 그리고 있다. 그래서 단독으로 생각이 있긴 한데 이쪽에 파이브 식스에서 보면 그 드레스에 대해 놓친이나 이런 것들이 어소시에이션은 1대1 훈련이 되어 있는 거 같아요. 일단 그 와이드패스 무빙한 와이드패스까지 약간 굉장히 일레귤러한 그런 생각하는 그런 게
이성준 선생님 의견 있어요? 일단 리드 원을 보니까 1부에 일단 안 보이잖아요. 사이너스 필름은 아닌 것 같아요. 이거 보니까 스터에서 약간 넓어졌다 좁아졌다는 것들이 보이고 가지고 뭔가 싱글 벤트리클라 디폴라리제이션은 아닌 것 같고 that's like a single maybe different way. 그다음에 여기 보시면은 와이드 큐어스로 바뀌었는데 이때는 사이클런스 빠르게 여기 보면 약간 마우스 이게 BT를 페이버한다면은 모노모티브 BT면은 이제 레귤러이라는 경우가 많은데 모노모티브 BT 치고는 이레귤러하게 보이고 그다음에 커플링 인터벌에 따라서 선에서 넓어졌다 좁아졌다는 걸 SBT의 프릭사이테이션 아니면 에버런시 둘 중에 하나를 보고 싶은데 if it is aberrancy, we can see the echelon phenomenon. Here, at the low Mara, then wide curves, no. So R interval is similar. So it is less like the echelon phenomenon. But if we see this point, low Mara, then wide still I cannot exclude the potential attachment phenomenon. But my first choice is atrial fibrillation with excitation.
So when the atrial fibrillation, ventricular response rate gets faster, if you know the conduction remains, your RR interval tended to regularize. Okay. But initial vector of the QRS factor, Papa pointed out, lead 1, and then also if you look at lead 3 and lead 2, they are all true bipolar. Okay. Other leads are modified unipolar. Okay. So those are going to be the best leads for you to look at the initial vector. So if you look at all 3 leads, initial Q width and also axis swing change. Okay. So that is what we call subtle activation in ECG. So when they change it, I mean your vector of ventricular activation is changing. I mean there is something else exciting the ventricle. That's one. Second is that as he pointed out, when you guys read the ECG first try to look at the P width. There's any P of evidence? No. The continued variation of S segment, PR segment, then RI interval slightly irregular. That's favored for fibrillation, for some sort of multiple atrial fibrillation. Okay? And in presence of that, patient has different degree of QRS duration as well. Look carefully. QRS duration is not the same. They're changing it. The degree of if this is the aberrancy, you shouldn't be, because you can have right or left on the aberrancy. Only other degree of QRS change would be a vesicular block aberrancy to the complete block on the breast aberrancy. So it's not there. And then also he pointed out D1, D2, D3, D6 are concordant, recorded concordance. Notching is RSR pattern that is consistent with DT. So only tachycardia can do that with D because atrial fibrillation is a pre-excitation syndrome. Next thing that let's go further. Where is this pathway? If this is a pre-excitation, and tell us that. That would be important for us. Now, what other DT can do this type of behavior? RR interval irregular. Only DT can do that would be automatic DT with the exit block can do that, but it's not. Why is that? Why I'm telling you that? QRS durations are pretty much similar, except a slight RR interval variation. That cannot happen if you have a focal exit. Second, automatic tachycardia tends to have acceleration exit block and terminate, not continue. So there's few things that is not standard. Okay. So if it is a pre-excitation, where's the pathway? So it's the left side, right? It's not right side, because your eyes are free. Delta is positive, first 40 millisecond. And then your 3 is what? Negative initial component. Lead 3, pre-excitation. Why the complex? Go to which of? Yeah, that's it. Okay. And then lead AVF, almost isoelectric. Lead AVF, AVF. Can AVF go? AVF. Yes. Why the complex? Yeah, the first initial almost isoelectric. So where would you say this pathway is? What kind of pathway does this?
He just finished the general cardio with EP special survival training.
Okay, good.
아, 저는 네, 케이스를 알고 있어서.
Yeah, so if you ask me, when patients present with the sudden cardiac death from WW, which pathway location is most likely cause of DFRS? Posterior and tended to be more posterior rather than anterior. Anterior tachycardia doesn't do it. And then also this patient, many of them have a very subtle pre-excitation many times, even despite those posterior. So you really need to take carefully those patients. When I was early training, I missed one of such a patient, young 21-year-old kid, exercise sudden arrest. Came to the emergency room And you can see I did a look at the EKG, and then I thought that was not excited. And then, so I did not think about the EP study. So when I went to present the case, my boss pulled me outside and said, he chewed me up so bad. He said, look, you think always young guy, most common things first, excitation. And so posterior stop thorax pathway, posterior pathway tended to do that, despite of the left side location. Okay, because of those people, avial conduction is very much in his flexible. But we need to be careful.
So we have a guest from Georgia, Dr. Roy Rashbaba. And please introduce yourself briefly, and I would like to listen to your opinion regarding this ECG.
Hello, my name is Roy Brown. I'm from Georgia Catholic Videos. So you say so many signs of against or sciences in supraventricular, I mean atrial fibrillation more, excitation, etc. For me, it's VT. For me, it's VT. It's quite. For me, it's not VT in general, but this positive concordance, first of all, it's very interesting for me. Second one, just in first eye, as we say, first eye of the QRS, then second eye is the higher than second. I mean, in every precordial leads. It's also interesting sign for me. It's very more than OBT. But yes, the size of this first choice for me is the atrial fibrillation with aberrancy or some atrial tachycardia because it's quite regular P or some P waves. It's not like in F waves in atrial fibrillation, maybe it's atrial tachycardia with aberrancy. And second choice, because I cannot fully exclude accessory pathway and atrial fibrillation.
What is your first choice?
Third choice, atrial fibrillation with aberrancy.
Aberrancy.
Yes.
So aberrancy or excitation. There's two choices.
Yes.
So can we exclude the potential VT? Less likely.
No, you may not be able to do that because of our first resident of the 56 that ended with cure at that much. She pointed out. That's already really or not? Can you exclude 100%? No, probably not.
Okay, then we have three choices: VT, excitation, and aberrancy. Number of VT vote. What's the chop? No, you change your mind. VT 0, and the aberrancy 1, 3, 4, and excitation 4, 5, 6. So excitation is highest number. Okay, so
Tell us the story.
Actually, I met this patient in ER and I choose most regular EKG. And after cardioversion, this let me show you the EKG.
Yeah.
minimum excitation, minimum excitation 2. Oh,
AVL is a cure, right? So AB one is a cure, so it's the left side pathway, right? Medium excitation. And the E1 is the RA with a slightly fixed side, but very small. It's most likely not left, purely left, probably also a lot of pathway, posterior pathway. Yeah. This is the commonest mistake.
I show you next one.
Okay, let's see.
Okay.
케이스야. 케이스는 하나도
Let
있긴
me ask
한데.
a question to the health team. So if you bring the patient to the EP lab, ablate only accessory pathway or AP together? Depends on.
Patient age.
Age, is. I missed the patient age.
Yeah, no, this tell me.
몇 살이에요?
62세,
62.
62.
Long reports. Why? Already oblique.
No, this patient, history is important. Why? Question that you should ask, how long he been having palpitation? Okay. If you have somebody has a postural, lateral postural subluxury pathway that has, congenital bone condition, haven't had it all life long, no problem. And then at the fourth, fifth decade, started a problem, has always triggered arrhythmia resulting excitation manifestation. However, patient is 18, 20 years old coming with this. That's what also. This patient has a hypertension. Look at the history already, right? And then he had, LPW 2023, so that was last year, right?
Yes.
So he have not had a treatment before, correct? I assume. Am I correct or not wrong?
Correct.
So he been atrial fibrillation since then. So I think this is a bystander pathway. No risk of a sudden death, which is important fact now, because not all posterolateral pathways are sudden death risk. So they should be managed at a young age, baby. So, but it's the fact that the patient is uncomfortable, you should be ablating. Well, that's your answer. Yes. Agree. Any other different idea? So atrial fibrillation is what trigger. I had a similar case in the not too long ago, last year. I think I went to Incheon. There's a Korean hospital there. They had a young lady came, who's 52 years old, hypertensive overweight, and she had a pre-excitation from the posterior subluxal pathway. So she had a sudden death. They studied her. There was a bleeding only pathway. In the EP study, we learned that she had right pulmonary vein focal tachycardia, actually triggering excitation. So her question was, we're just going to let it slow pathway. I mean, pathway. I said, no, your primary problem is not the pathway, it's the tachycardia that you have to blame first. So we had a discussion about it. So it is important to find out our clinical perspective, what you're going to do in the lab, not just looking at the pathway. In other words, treat the patient as a whole, don't just treat everything. Okay, that's the bottom line message here.
I will. We see in the even the young patient or the middle-aged patient, we see their induced atrial fibrillation during SVT ablation, excitation. So how do you deal with? Never documented atrial fibrillation, but only each time we saw those patients pumping. So what is your strategy for those? It's a very important issue for fellows.
For the hypertension. First, it's not a military fibrillation only. Iatrogenic fear. But I explained that your patient, they're bending, you have some risk for atrial fibrillation. So if the patient has no event, then I will wait for 5 minutes and then I follow the patient just one time. But if I found the new atrial fibrillation in the deep leg, then I will regularly follow the patient and in more attention and more prolonged treatment. But we cannot avoid atrial fibrillation in our system.
So you don't prescribe the interesting drug.
And yeah, usually.
If it is young patient,
Just the clinical.
Sometimes young patient have double atrial fibrillation and they come to my clinic to undergo an double ablation and after double ablation, if it gone, yeah, it gone. So with oxidative pathway usually sometimes they induce after ablation without any flow.
What if we don't know implant?
Or we don't know that, does they have a family people?
Yeah, yeah.
Sign
Well,
it.
If you implant.
There is a, so let's step back one step to the teaching for fellows. What is the role of atrial fibrillation in WW patient during the healing? What is it? What is the clinical information you can get from that?
first one is atrial fibrillation, associated atrial fibrillation includes the risk of sudden death.
Well, that's given.
And
But,
the other one
Uh-huh.
is accessory pathway perpetuate atrial fibrillation by the mechanism of source-seek mismatch.
correct.
Yes,
Now,
either way is
beside that, let me tell you a story about WW. When John Gallagher in Duke, when he started studying atrial fibrillation in 1970s, 80s, he purposely induced AFib with every single patient. Okay? And you know what's the reason? When patients present atrial fibrillation and WW in clinical scenario, they tended to have a more multiple pathway. That's number one. So he used the atrial fibrillation, looking at the delta wave pattern. If you present more than one, then you got multiple pathways. Retrospectively, that's the truth. If you induce atrial fibrillation frequently in the lab during the ET study in WPW patient, make sure you don't have a multiple pathway. Okay? That's why they increase the high risk of sudden death. That's the number one message to get. Second is that there's a variety of mechanisms of Dr. Park discussed. Pathway can include induced atrial fibrillation. But if young patient never documented the atrial fibrillation before, you just ablate and then you just follow. Why is that? Because even though they may have a very small chance of atrial fibrillation, they're not going to have a sudden death. They're just going to come to you palpitation, normal structural heart tended to be. There's a risk of stroke very low. But there's no justification to try to give that antiarrhythmic. Okay, that's the clinical message in general consensus we have. Therefore, ablate the pathway, observe patient. That's all. You don't need anything else. And then if patient presents with the fibrillation afterward, then you can think about different mechanisms. There was a paper written about 1994 by a German group looking at the debate whether you ablate the atrial insertion, then ventricular insertion, because atrial insertion tended to be multiple fiber insertion versus single ventricular insertion, post-collateral pathway, for example. You ablate the ventricle side, you will eliminate the only ventricular insertion, but atrial pathway connections still remain. That short circuit can cause atrial fibrillation. There was such a paper written by German guys. And there's some argument about the, as you discussed, in sequence source mismatch, things like that. But we really never proved to be anything systematic data analysis. Therefore, still argument that don't do anything. That's okay.
that there was an old paper there. After, if the patient has both documented atrial fibrillation WW, just ablating the bypass tract, 50% of patients never shows atrial. But it was very, very old paper.
Right.
But still, we don't have a systematic
No.
study
We
for
don't.
long-term follow
Right.
those patients. And I leave the atrial fibrillation and the close follow as Dr. Yu did, and I saw the eventually documented atrial fibrillation from time to time.
Yeah.
Even the age of 40 or 50.
Incidence are very low. So I think you have to understand, for example, similarly, that may be proportional to the number of RF lesions you deliver to the microgravity annulus. Number one. Number two, how do you approach it? It is truly true. If you do slow pathway ablation, atrial flutter ablation, those patients tend to have a more right atrial arrhythmia when you follow long term because of scar growth. Typically, right post-collateral atrial flutter. the San Francisco group published a paper from human. Yes, they did, no China. So it is, you don't want to ablate the things unnecessarily creating lesion into the heart. It's not really that harmless as we think. So I think we need to be target much as specific we can, deliver minimum lesion. That's particularly true. This young man's vision for children's very, very important. Also, as we know, lesion size grow as the child get older. So growing age, we need to be careful. So I think this message is so important that in mapping carefully, target specific. Don't try to go all over the place.
Is that the reason Dr. Ohm's patient so many atrial fibrillations?
No.
이제 다음으로 잡힙니다.
Our question is, your patient was with the accessory and left right pulmonary vein focus. for a
Mhm.
long time. Okay, what is the strategy? You ablate accessory pathway.
No, we ablate a puppy first, then ablate the
How? One single isolation.
Yeah,
one
one
way.
single vein isolation. Actually, we did a focal ablation. It's a PV tachycardia,
Right.
not AFib.
Okay,
So with this high resolution mapping, you can actually find the focal trigger inside the PV. Usually secondary angina, but it comes from our experience. So we have a discrete ablation. We learned that irrigation ablation is different than resisted old thermal injury ablation in PV. So irrigation appears a little safer because lesion is deeper.
yes.
So therefore, we deliver 25 watts, 4 burns in the secondary final atrial pulmonary vein. Initial venogram, post-venogram, no stenosis, and then normal got it. It went down to the posterior start 3 burns and inside the sinus.
Okay.
MCD.
Today is Dr. Haas' last day. We detail patient to prepare another case.
Okay,
Please.
yes.
사실 디스커션이 좀 별로 없을 티피컬한 케이스라고 생각을 하고
It's a very interesting case, a lot of teaching points.
네.
Very happy, yes.
말씀하신 대로 AP의 액세서리 패스웨이가 레프트 라테랄 월에 있었고 이제 AP 어블레이션과 액세서리 패스웨이를 어블레이션 했던 케이스였습니다.
네.
두 번째 케이스는 제가 사실 최근에 스텝 선생님께 노티를 했던 거긴 한데
네. Okay.
Sweetie, 80. Yes, sweetie. The LLC or fixed on the bridge. Which one? Diagnosis. That list. 8%. 네. 하나를 네.
그리고 이 케이스는 제가 그 스텝 선생님께 질문했던 포인트가 또 따로 하나 있었는데 혹시 뒤에 텔레메트리를 하나 좀 보여드릴 수 있을까요? 정보를 하나 드리자면 이분은 이제 DDDR 페이스메이커
Okay. Go back to the EKG. Okay.
네.
Yeah, group of all of them, just like that doesn't bundle for into a program. Now I'm very careful about things. Cardiologists like to mention about left bundle right now, or with not left and not right, and I don't know what kind of pseudo roadblock is it. So I, because we are starting as from P, where is P? I think it's like more of retrograde teaching need to. But I'm not sure about them between two diagnoses. It's some AVRT tachycardia. They most like heavy NRT. Because between so less than 18 seconds. Let's see here. And seconds. But not we exclude. How to say? Is speaker to start yeah, include that.
Although that is if you're the pacemaker tachycardia, you have to have an upper rate of PMT, right? And this tachycardia, because how fast it is, you do not program this fast for the patient, unless you have a specific reason for it. Okay? And you don't see ventricular pacing. PT, no, so that's why I exclude that off. So, okay, so where do you think that this patient keyword? That's the first thing for fellows. Just guess. Tell me where you think the keyword is, where to where. That would be important for you to look at this. Okay. When you say typical lap bundle, okay, would you see lead to terminal S? Let me ask you that question. That's small s, right? This one, not this one. Okay, yeah, and the cube right there, right? And then you got also in the B5, right? So you have lead one also has S, right? Small s. And the second thing that you need to watch, usually T wave follow the QRS complex, normal ECG, right? When the TR is up, QRS is upright, T wave will be upright as well. And then the obviously the fundamental flag, you can change that. But you can see lead one, T wave will try to follow, but the initial deflection kind of a depression there, right? This very application. Such a lead 1, 2, and even APFs. Do you wonder that the second wave is summating at the top of that cause this? If that's a scenario, then you can start thinking, if this is a floor 2 to 1, differential diagonal P. Or our colleague here said that the retrograde P is right in the QX complex, become that. Then retrograde P duration has to be reasonably wide. So those things you can think about it. But this appears to be typical left bundle average pattern. And but the QRS is a little bit narrower than true average. That's what's somewhat unusual, but that can happen depending maybe on the reflection. So bottom line is either you have a floor 2 to 1 differential diagonal of heading, and you may have ADRT or ADNRT. But if you look at the S wave determinant QRS, maybe either way you cannot tell difference because QRS is already one. So maybe slow ADNRT or AVRT or floor 2 to 1 that you can think. But least we can say that based on the mechanism of tachycardia does not appear to be automatic tachycardia. Gotta be BNP. Why? So regular. Okay. If you see 12 ECG, RR interval vary, then you may argue this could be automatic tachycardia. But when you see such a regular pattern, always favor for the infant. So this is we're going one step forward. Okay. Any other comment? Okay. Next slide. Let's take a look. What do you see here? Is this pacemaker working? Not working? First thing. Not working. Falling all over the place. So then, what you say? Non-sensing is capture, non-capture. So this pacemaker, atrial lead probably, most likely atrial lead. I don't know the ventricular pacing, but these possibly ventricular pacing also could be, but we can't tell sure. Unless the interrogation, or you can say, whatever this pacemaker doing is not capturing, is not sensing. Tachycardia is going. Okay, so gotta be faster than pacemaker program rate. That is another argument against the pin. Okay, now do you see more clear-cut notching into the QRS complex? Now you see it, that noisy, right? And now you favor what? Can you still exclude the atrial flutter 2 to 1 or not? No. You cannot, because it fall right into the QRS complex. If you measure, right? But if you look carefully, very last bit of the bottom spacing, that one, we'll go to look at the P wave. Go to the P wave. Yeah, go that notching in there, right into the QRS. P wave, right? So if you measure that, most likely that's 2 to 1 right there. There's no reason to P wave have deform as well. In other words, QRS, P are absolutely refractory to the atrial ventricle. Therefore, there's no really reason to deform that P wave, unless it's a secondary activity going on. That it is probably 2 to 1 conduction going on. That would be favorable, flutter 2 to 1. That's what I would favor.
Pacemaker sensing is 2 to 1.
Yeah, it's possible. Yes, right. Yeah, it's a large part of tracing. Yeah, but I don't think it's capturing. Maybe capturing. Yeah, the information from paper. Yeah, it is true. So, but if that is a capture read, then subsequent tachycardia rate should be resetting or something happening. Then you do IVL connectivity, but that's not a fit. Maybe the pseudo fusion pattern. I think it's pseudo fusion because if you look at carefully, spikes that are sub the P wave changing a little bit. So that's a pseudo fusion. Okay. So what is the story?
네, 스토리를 더 드리겠습니다. 저희가 베타 블로커를 애더하고 그
아하.
후에는 이제 다음과 같이 APVS
APACE.
네, 나왔었고요. 패스트 심점으로 보여드리면 이분은 워낙에는 APVS의 페이싱이랑 PAV가 조금 길었던 환자라고 할 수 있고요. DO에서는 다음과 같이 이디오 벤트리큘러 리듬이 나오던 환자였습니다. 환자는 박테리아 메닝고 엔세팔라이티스로 입원하신 상태고 와이드 QRS 타키가 있어서 이제 뉴로로지스트가 급하게 연락이 와서 봤던 분입니다. 페이스메이커 인터로게이션은 이제 최근에 했을 때는 이제 워낙에 에이페이싱이 90% 이상이었던 환자였고요. 에코에서는
What do you operate the pacemaker program? Operate
오퍼레이트 프로그램
1 to 20?
yes,
1 to 20?
네, 120회 70. 네, 환자는 이제 지금은 현재 sepsis에 대해서 치료를 받고 있는 상황이고 체스트 엑스레이 다음과 같았고 지금은 블러드랑 CSF에서 리스테리아가 나온 상태로 저희가 모니터링하고 있는 중입니다. 네.
The first EKG you show us, what was the tachycardia rate there? I thought it was faster than 120. No?
150회 네.
Alright. 왜냐하면은 these days the dual chamber pacemaker will capture slips is so narrow and then also sometimes very difficult to see in the pacing spike. Okay. So sometimes it's always you check the pacemaker upper rate and then the tachycardia rate. Sometimes that's what we use. Okay. It's pacing technology, implanted skills are into so much. All the time, future patients know that they're not anymore. So we really Okay,
네.
very good.
에이,
Thank you.
네,
Very good. Okay, now,
고생 많았습니다.
네, 수고하셨어.